Hey, good evening, everyone, and welcome to Take Charge for March of 2015. So our topic tonight is coronary artery disease. And I believe everybody in the audience here is aware that coronary artery disease is one of the leading causes of death in North America. Having said that, I'm happy to say that it's a very, very manageable condition. Dr. Kavanaugh, who founded this very program back in 1968, was very fond of saying that a big part of heart disease was lifestyle. And he felt quite strongly that if you could get your lifestyle under control, you could have a very positive impact on coronary artery disease and leading a nice, long, healthy, productive life. And that's why so much of the education that we do revolves around controlling your risk factors and making sure that you exercise regularly. We also know that it's very important that you learn as much as you can about coronary artery disease, because the more you know about the condition, the better you can manage your risk factors, and that leads to significant improvements in terms of your outcomes. So with that thought in mind, our speaker today is Dr. T.J. Yeo. So Dr. Yeo is an associate consultant cardiologist at the University Heart Center in Singapore. And we're also very lucky because he's elected to do a one-year fellowship with us here in our Toronto Rehab program. And he's been with us for I think about 8 months now. I know he's staying with us till June, and if you ask Leslie and Ryan and all the other staff, we're going to be heartbroken when he leaves, because he truly, truly is a wonderful, wonderful man. So Dr. Yeo is going to be talking to us about coronary artery disease. TJ, you wanted a short and sweet intro. I think I've done that. Everyone, I'm going to turn you over to Dr. Yeo, and I'll be back at the end of the session to make some closing remarks. Thank you, Dr. Yeo. All yours.
Okay, so a very good evening to everyone. Thank you so much for coming by tonight. It's very good to see such a great attendance. First things first, can everyone hear me clearly, including the people right at the back? Okay, if at any point in time you find that my volume is a bit low, please let me know, put up your hand, and I'll be happy to repeat what I say. So today I will talk about coronary artery disease. I'll give a brief introduction, talk about atherosclerosis and how it leads to cardiovascular disease, a brief something on chest pain and angina, and about heart attacks, as well as preventing heart disease and the risk factors. So now, very, very quickly, you may have come to know heart disease or coronary artery disease by a few other names. Ischemic heart disease, coronary heart disease, coronary artery disease. For all intents and purposes, to us, to all of you, it's actually interchangeable and it means the same thing. To the medical doctor, there are subtle differences, but it doesn't really matter. I'll just quickly go through. Now, ischemia or ischemic heart disease means that there is not enough blood supply to an organ. That's about it. There can be ischemia to any part of the body. So for heart, it's called myocardial ischemia, or the heart muscle not getting enough oxygen or blood supply. Now, the word coronary is the name of the blood vessel. It refers to the blood vessels specifically that supply the heart muscle. And the ones that we are in particular interested in are the arteries. Okay? So if there are narrowing or blockages in the coronary arteries, it leads to lack of blood flow to the heart and therefore ischemia. And that's how everything is linked. So this is what the heart really looks like. It's not the red heart that you see on Valentine's Day, you know. So there are 4 chambers, and there are 2 of the chambers are smaller, and on the top of the heart is called the atrium, and 2 chambers are at the bottom of the heart called the ventricle. Now, going back to coronary arteries, we are interested in the arteries that help supply the heart muscle with blood so that it can pump and function properly. If you can see here, the red little lines are the coronary arteries. And all the words over here refer to the names of the coronary arteries. Basically, they're named after the anatomical position. So those on the left side are called the left coronary artery. Splits into, my pointer is gone, splits into a large one called the left anterior descending and the circumflex artery. and there's one on the right called the right coronary artery. So all these come out from the main blood vessel called the aorta, and they travel on the surface of the heart. And then the branches go within the heart muscle and supply the heart muscle with blood supply. So, looking at the blood vessel itself, what does a normal artery look like and how does that compare to an abnormal artery? On the top, you can see that this is a normal artery. It looks like just a plain tube that's hollow in the middle. So blood can flow through this tube very, very smoothly. Clearly, there is a abnormality here in the bottom picture. This shows the collection or accumulation of plaque and leads to the artery becoming narrow. So looking at the cross section, you see that the amount of space available for blood to flow through is significantly less in the artery below. So plaque is also known as a collection of fatty substances, and I will show you a video in the next slide to explain more. So I talked about atherosclerosis. Basically, it's just a long and complicated word describing the formation of plaque in the coronary arteries. So the plaque causes hardening and narrowing of the arteries and basically restricts the blood supply. As you can see over here, it's a huge traffic jam and all the vehicles are basically caught in the bottleneck. So that's what happens if you imagine the vehicles are your red blood cells, and then the bottleneck is caused by narrowing in the coronary arteries. The vehicles can't pass through. So that leads to reduction in blood supply. So to help you visualize, let me show you a video.
Atherosclerosis is the buildup of fatty deposits, including cholesterol, in the walls of arteries. It's a major cause of cardiovascular disease, including stroke and heart attack, and contributes to the death of around 70 million people worldwide every year. This short presentation illustrates the key stages in its development and its main impact on cardiovascular health. Cholesterol is a natural, fat-like substance and is essential to health. However, too much cholesterol in your blood can be harmful.
This is the interior of the coronary artery,
but can also be found in certain foods, such as those high in saturated fats. There are many types of cholesterol. The main type involved in atherosclerosis is called LDL-C, or bad cholesterol. Another type of cholesterol, HDL-C, is called good cholesterol. It's important to increase HDL-C as well as reduce LDL-C when treating high cholesterol. A normal artery wall consists of three main layers: a thin, smooth layer that lines the inside of the artery to help blood flow, a muscular, elastic layer that helps the artery pulse to push blood around the body, and a tough outer layer to protect the artery. The exact cause of atherosclerosis is not known, but several factors, including smoking, high blood pressure, diabetes, and high cholesterol, are known to damage the smooth lining of the artery and contribute to atherosclerosis.
I will be going into that later.
Once this layer is damaged, the bad cholesterol, LDL-C, can get into the wall of the artery. There are four key stages in the development of atherosclerosis. The body tries to defend against the invasion of LDL-C into the artery walls by activating specialized cells called macrophages to consume the LDL-C. They become enlarged cholesterol-enriched cells called foam cells that are embedded in the vessel wall. The accumulation of foam cells can be seen by the presence of fatty streaks in the vessel wall. As the fatty streaks grow, the body tries to protect the artery from them by surrounding them in a fibrous capsule. At this stage, the growth is called a plaque. As the plaque gets bigger, the body tries to preserve the blood flow through the artery. The plaque expands into the elastic layer, which stretches in order to keep the opening of the artery the same. If the plaque continues to grow, its expansion will eventually intrude on the inner opening of the vessel, as the elastic layer cannot stretch anymore. This reduces the ability of blood to get through the artery. At this stage, physical symptoms such as angina may appear. Also, over time, calcium may be deposited in the plaque, making it hard and inflexible. This reduces the ability of the artery to expand to increase blood flow when needed, for example during exercise. As the plaque grows into the artery opening, it squeezes the blood through an ever smaller gap. The resulting increase in pressure at the narrowing can damage the capsule covering the plaque, which may then rupture, resulting in a blood clot that can completely block the artery. Depending on the location of the blockage, the consequences, such as stroke or heart attack, may be severe and could be life-threatening. Atherosclerosis is progressive, and it can take many years before symptoms appear. But some people can have no symptoms even with extensive atherosclerosis and are at risk from sudden death.
So I hope that short 3D video clip is, gives you a better visualization of what happens in atherosclerosis and plaque formation. So how does that translate into cardiovascular disease? Now let's take a step back and look at the bigger picture. So in Canada, it is actually a very serious problem. It's the second leading cause of death after cancer, and together with with cancer, the top two causes of death, it's responsible for more than half of all the deaths in Canada a few years back, and it has been on an increasing trend. So in terms of absolute numbers, almost 70,000 deaths were attributed to cardiovascular disease, and translated that into time frame, every 7 minutes somebody in Canada will die from heart disease or stroke. Okay, so just going back to atherosclerosis again, this is basically what you saw in the video earlier on. The progression of a normal lining of the blood vessel. So the blood vessel lining is called endothelium, and how it progresses forms a plaque and leads to the final event called the plaque rupture. So this is a 3D diagram to show how it progresses, and basically most of it has been covered in the video. But let's talk about the clinical consequences of atherosclerosis. So when somebody has diseased blood vessels of the heart, it contributes to narrowing of the blood vessel. If that happens over years and years and the blood vessel becomes narrower and narrower, what happens is that symptoms will develop because the blood vessel doesn't let blood pass through. And I will go into that. It can lead to angina or chest pain. What happens when something happens to irritate that plaque and cause it to be damaged? Earlier on, you heard the term plaque rupture. So basically, there is a protective cap on top of the plaque over here with my arrow, as you can see here. So triggering factors like excessively high blood pressure or stress, whether it's a physical stress, heat, mental stress, etc., it can irritate this layer and cause it to rupture. And when it ruptures, it's a dramatic event, as you can see over here. The contents of the plaque get exposed to the bloodstream, and the body's natural instinct is for all the blood cells and the components of the blood to come and attack and clump together to cover up this foreign substance in the bloodstream. This leads to complete blockage of the blood vessel and consequently causes a heart attack. So basically, this is what I mentioned earlier on. And the ironic thing is that if you talk about a blood vessel with a 90% blockage versus a blood vessel with, let's say, a 50% blockage, the one with 50% blockage potentially has a higher chance of rupturing than the one that's 90%. Why do I say that? Because over time, the plaque actually gets stronger and harder, and the cap becomes thicker, so it's more difficult to rupture. So blood vessels that have blockages of up to 90% usually happen over a long time, and they cause problems like chest pain and angina, but usually not sudden blockages. However, for the blood vessels that are usually 50-60% blocked, they may cause problems and rupture after being exposed to stress. I will go into this a little bit further later on in the talk, but essentially it doesn't mean that when you have a 50% blockage you have to treat it by stenting. That's not what I mean, but rather you have to take your medication and use ways and means to try and reduce the risk of this plaque rupturing. And one of the medications that I'll go into is the cholesterol lowering medications called the statins. Now quickly let's move on to symptoms. And I'm quite sure most of you personally may have experienced these symptoms. So I love to use this picture. This is adapted from one of the medical atlases for cardiology. And it tells us very clearly just by looking at this picture what the classical signs or symptoms of angina are. So you see that this is a picture of a gentleman just coming out of a restaurant. He's climbing a small flight of stairs, clutching his chest on the left side, and he's dropped his suitcase. And at the same time, he's dropped his cigarette on the floor as well. Do you see that? And the wind is blowing, the weather is cold, he's dressed in many layers. So this picture alone has demonstrated almost all the signs and symptoms of angina. So what can trigger off angina? Taking a full meal, cold weather, exertion, smoking. Just now I mentioned high blood pressure. So what happens is that there is left-sided chest pain that travels down the arm, as you can see in the smaller picture inset over here. So how did angina get its name? Angina means strangling in Greek, and pectoris, which is the full name of the symptom, means chest. So it's basically a strangling feeling in the chest. So we always look for classical features when we talk to patients and we ask about symptoms. So there are many descriptions. Some say that they have chest discomfort, but typically the location of the pain is either in the middle or slightly towards the left side, and it can travel down to the left arm or up to the jaw. It is usually associated with breathing difficulty and is made worse with exertion and relieved by rest. So if anyone has any or more of these typical factors, each additional one tells us that the likelihood of this being really angina is higher. The pictures below tell us that angina can happen in many locations. It can happen in the neck, can happen in the chest, can happen in the back, in the shoulder, etc. And that is why it is also called the Great Pretender. So a lot of things can mimic angina, and angina can also mimic a lot of things. So unfortunately, if somebody doesn't have the classical symptoms, then it makes the diagnosis a little bit tricky, which is why a lot more tests need to be done. But as you can see over there, there are many descriptions of angina. Some people say discomfort, some people say pressure, heaviness, tightness, squeezing, burning, choking, etc. And the location, like you saw in the various pictures below, can vary significantly. So to tell whether angina is typical or atypical, we look for additional information. For example, what triggers it? You saw in the picture earlier on, exertion and a full stomach or emotional stress. And associated symptoms, if there is cold sweat, if you find that there's difficulty breathing, or if there's nausea. So all these are typical symptoms associated with angina. Next, to give us clues whether angina is genuine or it's something else, we ask for duration. A chest pain or chest discomfort that lasts 1 second, chances are it's not angina. Same goes for chest pain that lasts many hours, for the whole day without stopping. Angina typically lasts a few minutes, between 5 to 15 minutes, and this is usually the duration. Now radiation. Radiation basically tells us, gives us additional information on whether it's angina. Typically, like what I mentioned, it goes down the left arm, up to the jaw. If it moves all over the place, first to the right, then to the bottom, then to the top, then to the back, chances are it's not angina. It might be muscle, because it may be related to movement as well. And the character of pain. Yes, I mentioned that there are many descriptions: heaviness, tightness, pressure, etc. But sometimes I'm just giving general statements. So some people have angina that are really atypical, but most of the time, if we hear somebody saying that, oh, it's poking, it's like a needle poking your chest, and if you use your finger and press your chest and you can trigger the pain, then chances are that's probably muscle. Okay, the classical angina character, just to refresh your memory, is squeezing, like I told you, is strangling in nature, and it's a heaviness in the middle of the chest. I put diabetics here because diabetics have a higher chance of presenting with very atypical symptoms, not like the usual angina. So some diabetics could have a full-blown heart attack but not feel any pain at all. So diabetics will have to have a much lower threshold for any symptoms. So here are some of the symptoms that I've mentioned. They are unlikely to be angina. For example, needle poking or very sharp stabbing pain. If it's worse with breathing, it's probably due to the fact that the muscles that expand your chest are being strained. And if you can press your chest and you trigger the pain, it's probably bony or muscle pain. Same goes for pain that's worse on movement. It might be related to the joints. Okay. And if, let's say, you have the classical symptoms, but they have been there for a stable period of time, you know exactly what triggers it off, and it happens, on a regular basis, it's been stable, manageable, that's called stable angina. But unstable angina is a whole different matter. It's actually a warning sign that your body gives you that a heart attack might be coming. So if the exact same character of angina happens when you're resting, it's very severe and it's new or more prolonged than usual, it may be unstable angina and you need to seek medical attention. So here is a quick review. You don't have to see the individual diagnosis, but just for you to know that many things can mimic heart attack or angina and vice versa. So taking a proper history for us is very important, and so is listening to what your description of pain is. Now let's move on to an actual heart attack and what to do and what is done when a heart attack happens. So when we say there is a heart attack, what do we mean? Usually we mean that one or more of the coronary arteries is blocked, and it's usually a sudden event. And because of this, the heart muscle does not receive blood and oxygen. Because of that, it gets injured, and if it gets injured for too long, the supply of blood and oxygen is cut off for too long, the heart will get damaged permanently. Okay? If you suspect that you have a heart attack, for example, if you have had one before and you have experienced the exact same symptoms, call 911 as soon as possible. Do not drive to the hospital because heart attacks have high risk of making your heart beat abnormally, and it can cause you to lose consciousness. So please do not drive yourself to the hospital. Wait for an ambulance to send you. And if you have a history of heart disease and you were prescribed nitro, use that for rapid relief. Nitro is basically a spray, most commonly prescribed here, to relieve pain by expanding or relaxing the muscles of the blood vessels. So if there is a blockage caused by a heart attack, by using nitro, it relaxes the blood vessels so that at least a little bit of blood may potentially flow through and give you a bit of relief and probably put you in a better state of mind to, head to the ER. It is temporary, so if it's a full-blown true heart attack, you may get temporary relief, but it will not last long. The pain will probably come back again. So what happens in the hospital? First thing that most hospitals do would be to do an electrocardiogram or ECG. If it's a clear-cut heart attack, it usually shows up very clearly. Yes, sir.
What about chewing an aspirin or chew aspirin?
Okay, yeah, that's a very good question. Maybe we can save that to the question and answer afterwards. But yeah, that's included as well. Usually aspirin is also recommended when you experience symptoms of a heart attack to immediately dilute the blood further and reduce the chance of further blockages. So what happens after you arrive in the hospital if you do have a heart attack? Besides doing the ECG, we also do some blood tests, and the blood tests basically measure if the heart is damaged. If the heart is damaged, it releases certain chemicals in the blood. So the most urgent attention will be given to somebody who has a sudden blockage of basically the whole blood vessel, and the degree of damage to the heart is significant. And we can tell this by the ECG. I'm sure some of you may have personally experienced it, where the moment you reach the hospital, you'll find that you're being told that you're being planned for an angiogram and potentially going for ballooning or stenting of the blood vessel. So that happens when the ECG tells us the heart muscle is dying and dying fast. The entire layer of the heart muscle is at risk. So that, in medical terms, is called an ST segment elevation MI or STEMI. So in those situations, clearing the blood vessel of the blockage is the most important. There are different degrees or degrees of severity of heart attacks. In situations where not the entire layer of heart muscle is at risk, there is a little bit more time that we can buy, and we can give treatment by medical therapy basically, and aim to do an angiogram within up to 72 hours. And in situations where the heart muscle is not at risk, which is probably just when there's chest pain, but the blood tests show that the chemicals that the heart muscle is supposed to release when they are damaged, it's not there, that means the blood test is negative, then basically it is not considered a heart attack. And probably an elective or basically non-urgent arrangement for coronary angiogram may be scheduled. So that's basically what is being said here. So in somebody who has had no heart attack but is at high risk, further testing may be done to ascertain whether there is truly ischemia or reduction in the blood flow to the heart, probably from narrowing of the blood vessel. So the various tests can be done. For example, stress testing, doing an exercise test, a nuclear scan, or an echocardiogram. And scans can also be done, like computed tomography or CT scans, to look at the blood vessels and whether they're narrowing inside. And that's not for everyone, because depending on the age and the degree of risk, sometimes the blood vessels are naturally on the rigid side and have a lot of deposits already, so this scan may not be for everyone. And of course, the gold standard is the coronary angiogram, which is an invasive method. I will go to that in a short while. Okay, so this is basically a very, very important slide. I've highlighted, or rather underlined and made caps in the first 2 points, because the first 2 points are arguably more important than anything you can do for treatment of heart disease. Lifestyle changes and medication are basically what you can do to help yourself and maintain this for the rest of your life. Coronary angioplasty and coronary artery bypass grafting, yes, they are very useful, they are life-saving, they increase lifespan, and they are very good for emergency situations or people with significant blockages, but they happen only at one time point. And they can always fail if lifestyle changes or medication are not being kept compliant with. So, coronary angiogram, I think I will skip the video. I will show you guys a video of the coronary angioplasty. It's basically the procedure where blockages in the blood vessel can be treated and ballooned or pushed aside as the treatment for coronary artery disease. And this is done invasively, but minimally invasive, through usually just a puncture wound in either the groin or the wrist. So a little wire is put in and threaded all the way up into the heart, and the culprit vessel is found by, again, using wires to look for the diseased vessel. What happens after that? tiny balloon is put in, going through to the blockage, and the balloon is expanded. Outside the balloon is a metal stent, and the stent basically plus the balloon pushes apart all the blockages, and the stent is left in place as a scaffold to prevent the artery from closing back again.
Is designed to restore the flow of blood through coronary arteries narrowed or clogged by atherosclerotic plaques
So that's
or
the
blood clots.
blockage over there.
When you arrive at the hospital, an intravenous line will be started.
Let's skip
You
all
will
that.
be placed on a heart monitor, and you will be given an oral.
Maybe I shouldn't have done that. Oh dear. Okay.
In your groin area
All right.
and inserts a needle into your femoral artery. Once the needle is placed, a guide wire is passed through the needle and gently guided through the arterial system to the heart. The needle will be withdrawn and exchanged for a small flexible tube called a sheath, permitting access to your femoral artery. At this point, you will be given a blood thinner to reduce the risk of blood clots. Next, a soft, flexible catheter is slipped over the wire and threaded up to the heart. The procedure is monitored using a continuous X-ray imaging device called a fluoroscope. You may feel pressure as the wire and sheath are inserted through the groin.
So for
and
those
pushed through the artery.
who have had
You
personal
will not feel the
experience,
movement inside.
so for those who have had personal experience, you will not know that this thing is going on, but finally you get to see what it's like. For those who have not experienced this, I hope you don't get to experience this.
Inside the coronary artery to be treated and inject a special dye. The dye allows the fluoroscope to take X-ray images
can see
called
the
angiograms of the
blockage.
artery's interior. Any blockages will be clearly identified as the arteries fill with the dye. You may feel flushed or slightly nauseated when the dye is injected. Once the blockage is identified, your doctor will insert a flexible guide wire into the artery and advance a balloon-tipped catheter over this wire and into position at the site of the blockage. Rapid inflation and deflation of the small balloon pushes the
Okay, so it basically pushes the blockage apart, and then a second balloon with a stent does the same thing, but the stent is inflated all the way to line the blood
vessel wall
vessel.
out, re-establishing blood flow through the artery.
Okay, I think in the interest of time, we will cut it short. Okay. All right. So this table contains the list of medications that are crucial to somebody with heart disease. All of them have, including lifestyle. So lifestyle is actually a crucial treatment as well. So you may or may not have one or more of these medications, but all of them have specific uses and for specific reasons. So aspirin, I'm sure all of you have heard of that. That's a blood thinning agent, and it's basically mandatory in somebody with heart disease or heart attack. The second one, which is called the P2Y12 inhibitor, is basically another name for the newer antiplatelet agents or blood thinning agents. So they consist of things like Plavix or clopidogrel and ticagrelor or Brilinta. The beta blocker and the ACE inhibitor are usually given together, very, very important. And next, the aldosterone antagonist. This includes spironolactone, if you've heard of it before, or eplerenone. These are usually given if, together with the heart disease, the pumping function of the heart is also very poor. If there is heart failure, this is very crucial medication. And the statin. Statin is one of the key things. It not only reduces cholesterol levels. I mentioned earlier on, you heard about plaque rupture and how heart attacks can happen when the plaque is unstable and ruptures. Now the statin not only reduces cholesterol levels, but it also strengthens and hardens the plaque cap, so makes it less likely to rupture, reduces the risk of heart attack in the process. So going on to risk factors, how do we prevent ischemic heart disease? Prevent a second event. All right. So there are many risk factors for heart disease. The common ones are the ones in the blue-black right on the left side. Basically, there are a lot more risk factors that are new and experimentary and being researched. But the ones on the left side are the traditional risk factors. And they can be divided into things that you can change and things that you can't change. So what you have to accept as a risk factor is your gender. Males have a higher risk, race, your age, and family history. But what you can change, there are a lot more things that you can change. Obesity, physical inactivity, high blood pressure, high cholesterol, diabetes, cigarette smoking, excessive alcohol, stress, all these you can change. And how can you change? Or what can you change? So this, obesity, basically, and hypertension, there are various guidelines and various limits. We won't go into that here, but you just have to know that these are reversible risk factors. But are they really that important? Okay, yes, they are, because these are things that you have the power to control and to change. So how bad is it? 9 in 10 Canadians have at least one risk factor of what I mentioned earlier on. So smoking, more than 4 million Canadians actually smoke. That not too long ago, that was the population of Singapore. Now it's 6 million. Obesity, so 60% of Canadian adults are overweight or obese, and arguably that is even a bigger threat than global warming. High blood pressure, 20% of Canadian adults have high blood pressure as of 2012, but the worrying thing is 17% is unaware of the condition. So in this group, I'm sure you are aware of how important blood pressure is. So try and monitor your blood pressure if you can on a regular basis. And if it's high, please get it treated or discuss with your physician about what to do with it. And physical inactivity, this is one of my favorite cartoons. And it basically summarizes everything very nicely. What fits your busy schedule better? Exercising 1 hour a day or being dead 24 hours a day? So just looking at that, you can tell how important physical activity is and how you can help yourself. Okay, so yes, we've always been talking about everything, being high and being big is good, but now we have to settle for lower blood pressure and less cholesterol. So how can you help yourself? Well, target and correct the modifiable risk factors, and up to 80% of deaths can be prevented. So as I mentioned, go for regular screening. Screening meaning get your BMI taken. Actually, you can do that at home even. Measure your height, measure your weight, calculate the BMI, check your blood pressure, check your cholesterol levels, check your sugar levels. Simple, straightforward screening, which I'm sure in this group, you're probably already doing it on a regular basis. Very importantly, take your medication. Lose weight by changing diet, exercising. The weight loss will come naturally. And reduce and eventually try and stop smoking completely. And finally, stress management. So basically, this is what I mentioned earlier on, the things that we can do for screening. And as long as you are above 40 years old if you are a male, and above 50 years old if you are a female, and have one of the above points, smoking, diabetes, high blood pressure, basically any of the risk factors that I mentioned earlier on, you should go for screening. Here is basically a brief slide showing the significance of body mass index or BMI and cardiovascular risk. So the higher the BMI, the higher the risk. And it's associated with a lot of bad things like diabetes, high cholesterol, high blood pressure, coronary heart disease that we've mentioned. And together, they even coined a term for it called the metabolic syndrome. So what is the metabolic syndrome? It's basically a collection of all these individual risk factors that add together and make a person even higher risk of heart problems. So not only that, it predisposes the person to cancer, in a lady's polycystic ovarian syndrome, and liver disease. So one of the things that one can do to try and counteract it is to get a proper diet. And I'm sure the dietitians here, the lectures that you have attended on diet, have introduced you to this Canada's Food Guide, and what components of the diet that you should increase, what components of the diet you should decrease. In terms of exercise, I'm sure all of you are very, very experienced. You have come through the program, you have spoken to our CRSs, exercise leaders, etc., and you are hopefully doing regular exercise on your own. Now this slide, I actually got from the ministry, or rather the Health Promotion Board of Singapore. So some components are not really that applicable to our population in Canada, but you get the point. Basically, even if you have no time to exercise, you have to do your daily activities. You have to do your household chores, you have to travel, you have to walk somewhere, and even leisure time physical activity can be used as a way to increase your fitness level. So, for example, in this, it says you can replace MRE station with subway. So, walking from home to subway, carrying the groceries, using some hand weights, etc. So these are all basically measures that you can do in your daily life on top of whatever your exercise prescription is with us, to increase your fitness level even further. And this is also a brief table that you should be aware of already, but you have your own personalized heart rate range. We always say take your 10-second pulse for those who have come through our program, and you know what your target level should be. This is basically for healthy individuals, and you find that as somebody ages, your maximum heart rate actually goes down. Your heart doesn't beat as fast as a young person. And basically, the more intense your exercise, the faster your heart rate goes. So we're coming to the end of the meeting, of the talk. Basically, moderation is key. Okay, as much as you want to exercise and you incorporate all these into your daily life, do not overdo it. Okay, listen to your body. If it tells you, if you feel like you can keep going, you probably can. But if your body tells you, you better stop, you're doing too much. Same goes for eating. If you can't gorge yourself further, then don't. Your body is telling you to stop. So listen to your body and achieve balance in life, and things will actually turn out better. So with that, I've come to the end of my talk. Thank you so much for your attention and your attendance. Thank you.